Good morning. This is Diane Perez. I have a couple of people who are saying they cannot hear me. Are you able to hear me now? Good morning, everyone. My name is Diane Perez, and on the behalf of Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Alternatives to Administrative Discharge, It's Time to Stop Kicking People Out of Treatment. This webinar is being made available through a collaboration of the Florida Department of Children and Families Office of Substance Abuse and Mental Health and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and the host. We will have some questions and time for Q&A, so if you please make sure that it's going to the presenter and the host, that would be helpful. The button to open up the panel is usually located in the upper right side of your monitor. Please use the Q&A panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Our audio is broadcasted through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options will be posted in the chat panel. So they already been posted, so if you go to the top of your chat panel, you'll find the instructions there. If you continue to experience poor audio through your computer, try rejoining the webinar and call in using the telephone I will call in option, which is also located in the chat panel at the top. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. So you must be able to view the PowerPoint. The recording and materials used in today's presentation will be available on the FADA website within 10 business days. To access the recording, it will also be located in 10 business days at the FADA website underneath the Resource Training Library, Resource Center Training Library. PDF version of this PowerPoint presentation will be emailed to participants. FADA produces many webinars and workshops through the support of Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to the evaluation form on the FADA website. You will first need to register or sign in to your account. So if you currently do not have an account with FADA, you will need to register in order to get to the evaluation. Information you provide FADA as part of registering remains confidential. Statements of credit will be posted within 10 business days after the evaluation closes. The evaluation will be closing on May 16th at the close of midnight on May 16th. Completing the evaluation is necessary to receive CE credits to access your statement of credit. 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license numbers for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside the state of Florida, you don't need to provide your certification number when you register with our site. Note, please, that WebEx monitors arrival and departure of attendees and provides a report upon completion of the event. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar. We are not permitted to provide partial credit. And now I would like to introduce our presenter, Gabriela Zapata-Alma. She is the Director of Policy and Practice for Domestic Violence and Substance Use at the National Center for Domestic Violence, Trauma, and Mental Health, as well as adjunct faculty at the University of Chicago. Gabriela brings 15 years of experience working with people living with HIV, impacted by housing instability, substance use disorders, and mental health conditions, as well as survivors of domestic violence and other trauma, providing direct services, training, advocacy, and consultation, and leading programs using a trauma-informed approach, motivational interviewing, harm reduction, gender response care, housing first, and third wave behavioral interventions. Gabriela has provided technical assistance through SAMHSA and other national leaders in best practices. Gabriela has been recognized with numerous awards, including Health and Medicine Policy Research Group's 2018 Health Award and the Illinois Association of Addiction Professionals, chapter of National Association for Alcoholism and Drug Abuse Counselors, 2017 Rising Star Award. Gabriela has provided training and technical assistance related to serving marginalized communities impacted by trauma and other social determinants of health, locally, nationally, and internationally. And now I would like to welcome our presenter, Gabriela.
Sorry. All right. So alternatives to administrative discharge. Some of our goals, so that's me. Some of our goals for today is to recognize some of the concerns and clinical practices that really are the drivers to increased administrative discharge. And as we identify those, we can also talk through what are some of the clinical and ethical problems that are raised by the practice of administrative discharge. And then, of course, we're going to come back to those solution focus. So what are some promising policies and practices for decreasing administrative discharge? You know, whether or not administrative discharge is something that we can wholly eliminate is unknown, but at least decreasing it and making sure that if and when it does happen, it happens when all other options have been exhausted. So first, what are we even talking about? What is administrative discharge? And so what we're talking about is the action of terminating a person from treatment against their wishes and counter to their treatment needs. So there's a lot of ways that we talk about administrative discharge. It can also be called involuntary discharge, disciplinary discharge, discharge upon staff request, discharge for cause. there's a lot of ways that we talk about this issue, but what it comes down to is that somebody needs treatment and somebody wants treatment. And us as a treatment provider, we are cutting them off. We are terminating them from our treatment services without any kind of transfer to another provider. And so it's wholly different from other common exit reasons. So it's completely different from treatment completion. It's completely different from when somebody leaves against staff advice. Sometimes people are lost to follow-up, or sometimes people say, you know, I'm really done with this, and even though we still assess there to be a treatment need, and it's wholly different from transfer as well. So something that we were hoping to get a sense of is how common is administrative discharge in your setting? So either where you work now or in a past treatment provider that you worked for, you know, if you can estimate how common it was. Let me see. And I might need a little help, Diane, to open up the polling question. Oh, there it is. It pops up on the right side. There's a polling question, and there you see. Oh, actually, that looks like the second polling question. Dan, are we able to pull up the polling question that has the percentages?
Yes, sorry.
No problem. Thank you for your help. So as we get that polling question pulled up, if you can think about, you know, even in like the past year, what the percentage was estimating of discharges were administrative discharges. So anywhere from 0% to less than 5%, 5 to 10%, 11 to 25%, or 26 to 50%, or over half of your discharges were administrative discharges. There it is. So thank you so much, Diane, for your help with that. So there is that polling question, and we'll give you a minute to enter your response here on the polling question. You should be able to just click right on your response. So you click on it, and then you hit submit. And we'll just give folks a few more moments to get their responses in. Great. So if we can see the results of that. And I'll need your help again, Diane, for this one to be able to see the results. Okay. So it seemed like 11 to 25% was the most number of responses, and then behind that, 5 to 10%, and then less than 5% behind that. Only 3% said 0, and only 1% said more than half. So this is a chance that I'd really love to hear from all of you as we go forward in the webinar. You know, I'd love to hear from those that are experiencing that, you know, 11% and higher especially the more than 50%, kind of what is driving that, what's making it hard to avoid administrative discharge. And then I'd also love to hear from those of you that selected, 0%, less than 5%, less than 10%, what it is that you're doing that helps decrease. So thanks so much, everyone, for that. So when we look at administrative discharges by service, this is 2016 data for publicly funded treatment. This is through the TEDS data that's organized through SAMHSA. We see that the vast majority of administrative discharge happens from the outpatient level of care and then followed by the intensive outpatient level of care. After that, we see that it's outpatient opioid treatment centers, which are largely going to be our methadone, buprenorphine, and a growing number are also offering naltrexone as well now. But historically and traditionally, more so our methadone providers. And then after that, we see it goes to long-term residential, short-term residential, detox only. And so we see that out of all the administrative discharges, nearly 50% were from the outpatient level of care. And then when we look at discharge reasons for outpatient-based medication-assisted treatment, particularly for opioid use disorder, we see that the vast majority are those that left against staff advice, or kind of, or we also call dropped out, but that over 10% were an administrative discharge. And so we know that medication-assisted treatment is one of the few evidence-based interventions for addressing the current overdose epidemic. And yet, the highest rate of administrative discharge at over 10% of exits, come from the outpatient level of care. So let's talk about, we talked about what is administrative discharge. Let's talk about who is being administratively discharged. So we don't have a whole lot of data on this, but the data that we do have points that the people who are being administratively discharged are more likely to be younger, more likely to have more severe substance use disorders and associated problems, tend to have more co-occurring mental health concerns, have a history of using violence, may have a less intrinsic motivation for recovery, and then also tend to have less recovery support from friends and family. So we see here, right, with that intrinsic motivation as well as that external recovery support from friends and family, people who have really reduced access to recovery capital, all of the internal and external things that really help us on our journey of recovery. And so what we see from this picture is that overall, the people who are most in need of our services and have the greatest barriers are the ones who are most likely to experience administrative discharge. And so why is this concerning? Well, I think that a lot of us already know why this is concerning, but just to kind of summarize, we know that we are in the grips of a horrific overdose epidemic and that our fatal accidental overdoses continue to increase with each year. We know that most people who need treatment are not accessing it. We know that when people are able to stay in treatment and complete treatment, they tend to have better recovery outcomes, and that the opposite is true, that when people are not able to complete treatment, that they tend to have worse outcomes, and that there are people, what administrative discharge tells us is that there are people who need to be in treatment, who are closed to treatment against their will and without transfer. And that doesn't make a whole lot of sense when we're in the grips of an overdose epidemic and just seeing all the ripple effects that has in a person's life and in the life of their families. So what are the drivers of administrative discharge? So now we're going to look at some of the system level, so kind of organizational level concerns, as well as some of the clinical practices that tend to increase administrative discharge. So administrative discharge, in sum, tends to try to solve these issues. These are the common goals that drive administrative discharge. And what our programs are hoping to accomplish with administrative discharge tends to fall into these main categories. So efficient utilization of treatment, the long-term financial stability of the organization or of the treatment provider, protecting the recovery of other people who are accessing our treatment, to prevent the concept of enabling someone's substance use, and you see their quotes there, and we'll get a little more into that. In order to uphold our professional reputation as a treatment provider. And then also we do have this ethical duty to address the lack of progress in treatment. Right? It would be considered unethical for us to continue collecting payment for a treatment that is not showing any kind of impact. And so we're going to take a deeper dive into each of these categories. So ensuring efficient utilization of treatment as a limited resource. So there's a few things that feed into this common goal. So one is this idea that we need to reserve services for those who are able to make the most progress in treatment. And what I want to really highlight there is how subjective that is, how it's based on our judgment of who we perceive or who we deem to be able to make the most progress in treatment. And that the flip side of that is that those that we don't see as demonstrating progress, we end up seeing as taking up this valuable resource from those who are more ready. And so what this leads to is screening people out of treatment based on our judgment of whether they are in, quote, compliance or they're, quote, ready, rather than screening people into treatment based on medical necessity. And as we know, substance use disorder treatment is based on medical necessity. And so we should be screening people into treatment because they need it, not screening them out because we don't think that they're, quote, ready. And so this is very much based on notions, kind of underneath all of this is this notion of who is worthy and unworthy of accessing treatment resources. And so while it's true that treatment can be a really difficult resource to access for many people in many communities, our focus needs to be on expanding access to treatment rather than rationing it out to those who we deem to be ready or worthy of services. And so that's one kind of piece that comes up and tends to drive administrative discharge. Another one is related to financial concerns. So this can come up when the client or participant, the person who's accessing treatment, lacks the financial resources to continue paying for treatment. It also comes up when insurance refuses to cover needed services. I remember sitting in a conference and talking about, the dimensions of the multidimensional assessment and when we determine that someone is ready to step down. And the conference presenters said, yeah, how often do we get to make this determination versus this determination is dictated by insurance, right? And it was a very large conference, and everyone in the crowd said, yes, absolutely, that's a huge barrier. And so it's a very real barrier that insurance may make determinations and refuse to cover needed services when the person still absolutely shows medical necessity. When there's lack of payment for copays and other required fees, and of course when other funding sources such as grants have become exhausted. And so in this common goal, when someone is administratively discharged due to inability to pay, as a provider, we're prioritizing the long-term financial integrity of the treatment provider over the immediate needs of the person living with a substance use disorder. And that's a very difficult reality. there are some other ways to address this need, but I'm going to get into that later as we talk through some of the solutions. And then the next common goal, protecting the recovery of others. And so in this situation, we view the treatment milieu, so the kind of the recovery community environment within the treatment setting, as a therapeutic agent in and of itself. That that milieu is part of what helps people recover and part of what aids in their treatment, and that milieu can be easily influenced and damaged. And so from this perspective, it's seen as we need to remove those who we believe are threatening towards the milieu in order to protect the recovery of others. And this is something that comes up very often. I saw it a lot when I was a treatment provider. I also continue to see it as I provide training around the country, that it's a really common concern. How can I help those who are farther along in their recovery if there's someone there who is, quote, triggering them or is somehow, threatening their recovery? And so we'll get into what we can do to be able to expand our services to help everyone, or almost everyone. Lack of engagement and missed appointments. So can I get a show of hands of how many folks have had someone miss an appointment? I should probably say in the last week, we'd all be raising our hands, right? It's an unfortunate reality that, especially in earlier recovery, there can be some rockiness when it gets to setting up that initial engagement and moving into that retention, that there can be a lot of missed appointments at first, especially as people make gains in their recovery. And that's for so many reasons. Transportation barriers are huge, childcare barriers are huge, and then just the natural ambivalence and the weaving path of recovery. And so this presents a few issues that tends to drive administrative discharge. One, of course, is lost revenue due to missed appointments. Even if we have kind of no-call, no-show appointment fees, those can be very, very difficult to recover, and someone might be likely to disengage if they're unable to pay that fee. And then, of course, there's concern for the stress that it puts on staff around billing targets, productivity, and missed appointments. And then we also have clinical concepts related to the readiness or the motivation for treatment. And if someone is missing their appointment, does that mean that they're not ready? Does that mean that treatment isn't a, quote, priority for them? As well as whether the treatment is effective or is right for the person at this time. And so all of these concepts and questions feed into driving those administrative discharges. And I'm starting here so that when we recognize these conversations coming up in our staff meetings and our supervision meetings, that we can start noticing, this is something that's driving administrative discharge. So I don't mean to be all kind of deficit focused at the beginning here. We are going to get into the solution focus of what we can kind of do about it. So to prevent enabling. So this concept of, if we continue to provide treatment and someone is continuing to use or not show up, are we just kind of adding to the disorder? Are we enabling the disorder? And so this concept is actually based on a lot of assumptions. I'm going to unpack some of those assumptions here. First, it's an assumption that the person is not making progress. So in the case of someone who has a recurrence of substance use or continues to use, that doesn't mean that they're not making some kind of progress. There's just how there's all kinds of things that happen before someone relapses. Like we say that someone relapses well before they ever pick up again. There's all sorts of internal things that happen and external things that happen before somebody reaches that point where they are really kind of consistently moving forward as we would deem or judge them to be moving forward in their recovery. And so there's a lot of positive changes that people can make even if they're continuing to use. There's also this assumption that people need negative consequences in order to start making progress. That's very much based on an assumption. Taking away treatment services is the only way to help someone is an underlying assumption, and that to continue to service the person would be harmful, another underlying assumption. And we'll get into later why and how these statements are assumptions and present clinical and ethical dilemmas for our field. And so the ethical duty to address the lack of progress. So we have a couple ethical duties here. One, to not continue to expose someone to treatment that seems to be ineffective for them and could potentially be even causing them harm. We know just as we have the capacity to help, we also have the capacity to harm. And the ethical duty to not add to the financial strain or bill for services that show no promise of effectiveness. So that we shouldn't continue to have someone pay us for a service that we're not seeing any signs is going to work for them. But none of this should mean terminating someone from care against their will and without transfer to another provider. We also have an ethical mandate to not abandon the people in our care. And then upholding professional reputation. And so I'd love to hear your thoughts here, if you can type them into the comment box. And I know that unfortunately you're not able to see each other's comments, so I'll read them out loud as you enter them. What are your thoughts on this? How might involuntarily discharging someone protect one's reputation as a treatment provider? Why might this drive administrative discharge? I'll give y'all a moment to type in your thoughts. All right, I'm not seeing any comments come through, so I'll give y'all some more time for the caffeine to kick in. Okay, here we go. Yes, thank you. So the fear of negative outcomes or liability, especially as it relates to death, potential fatal overdose being an example. Yes, maintaining a safe environment for recovery. Increasing successful completions, yes. Well, there can be a lot of fear around what happens to our outcomes if we continue to serve people that don't seem to be making any kind of meaningful progress. Yes. Thanks, everyone. And so here are some additional examples of how some of the things that drive this goal of upholding professional reputation. So there are several concerns that feed into this goal. The program being viewed as accepting of what is considered, quote, bad behavior. And with this comes a potential fear of, if people find out, for example, if people find out that you can use and still be in this program, then everyone who wants to use and still be in a program is going to come to our program, right? So that can be a potential fear that comes up in wanting to uphold professional reputation. The program being viewed as ineffective. Oh, well, that's where you go if, you don't want to make any progress. Look at the people who are there, right? The fear that clients who are more ready, quote, or more motivated, quote, for treatment will seek out other providers, while those who are labeled not ready or unmotivated will flock to our program. And then, also fear of loss of community acceptance and or respect. We know that part of the reason why treatment can be so difficult to access for so many people in so many different communities is because while we know that treatment is necessary and required, and especially during our overdose epidemic, that so many communities don't want treatment in their community, right? It's kind of like not in my backyard mentality. And so this fear of, what happens if we lose that community acceptance or respect? Will people be, lobbying to close our doors or make us move? And along with that, the loss of support from stakeholders. So moving into clinical and ethical dilemmas raised by administrative discharge. So here we come on to our second polling question. What do you think happens after administrative discharge? So what happens to most people after they experience administrative discharge? This is just a perspective question. So it's not based on data. It's not based on evidence collected by our organization. Just, what do you think happens after people after they're administratively discharged? So A, they find other treatment services on their own. B, they go back to or continue using substances. C, they hit bottom and start taking their recovery seriously. D, all kinds of bad things like higher risk of homelessness, contracting HIV, incarceration, etc. Or E, I have no idea. And we'll give you just a minute to select your response. Okay, and if we can go ahead and see those poll results. And we'll just give that poll a few moments to tally up the results. All right, so 1%, one person said, I have no idea. Thank you so much for your courage and your honesty. It's wonderful. So 4% thought that they find their other treatment services on their own. 4% also thought that people hit bottom and continue and start taking their recovery more seriously. About 30%, which was the leading category, thought that they will go back to could either return to using or continue using. And just beneath that, 21%, so a little over a fifth, saw all kinds of bad things, including homelessness, incarceration, things like that. Thank you so much, everyone. So, administrative discharge for substance use. So considering that entry into a treatment program is based on the person demonstrating medical necessity for professional intervention to be able to address their diagnosed substance use disorder. And so when individuals experience continued use or a resurgence of use while in our treatment programs, that we need to view that as confirmation of the very disorder for which they're seeking our assistance. And so it's not something to be punished, but rather something requiring our help and support. And this becomes very obvious when we have a really solid understanding of some of the neurobiological effects of substance use. When we can understand how longer-term effects of chronic substance use leads to certain neurological pathways in our brain becoming wired, becoming really organized around seeking out substances, using substances, increase in impulsiveness, decreases in, all of that prefrontal cortex activity of the control and the kind of planning, and that especially when someone experiences a cue to use, so that our memory and our learning circuits are really impacted by long-term substance use, so that things that remind us of use lead many times for us impulsively seeking out that use. These are things that people are seeking our help with. And so it doesn't mean that our treatment isn't working, and it doesn't mean that they're somehow wrong or bad or deviant or not trying. It just means that they qualify for our services. And so something to keep in mind is, what if other healthcare professionals discharge their patients due to a symptom of their condition, right? What if somebody who was treating diabetes discharged their patient due to high blood sugar? Or what if somebody, a cardiologist treating high cholesterol discharged their patient due to high cholesterol, right? That would seem so incredibly absurd to us. It would seem like, well, we have to change the medication, we have to maybe add a nutritionist, we need to work with them and see what kinds of lifestyle and behavioral changes they're able to make, what supports are needed in place in order to better help them, how can we simplify the process for them, what family support is there, what other kinds of social support. We would look at a whole host of things. And so this raises a really important question of behavioral health parity. We also see that within administrative discharge, there's a misunderstanding of the role of self-determination and self-efficacy in recovery. And that self-determination, so making our own decisions and being able to carry out our own decisions, so overall our decision-making power, especially as it relates to substance use, is the goal of treatment. So it cannot be the requirement of accessing or remaining in treatment. This is exactly what we're hoping to help people with through our treatment. So this raises the question of whether, when administrative discharge regarding due to continued substance use is an issue of perspective. And so we have many different ways of understanding substance use and substance use disorders. Two of the major ways I highlight here, a moral model versus a disease model. So a moral model puts forward that the problems of substance use are some kind of moral or spiritual failing on the part of the person, and that negative consequences are necessary for the person to be willing to change. And so in this model, administrative discharge creates an opportunity for reflection and building motivation. The disease model will look at substance use disorder as a chronic condition, meaning a long-standing condition that worsens when it's not effectively treated. And so administrative discharge does not create an opportunity, it does quite the opposite. It disconnects the person from needed health care, and it delays the discovery of what treatment will be best in helping them. And so looking at, it's not the person that's not working, it's the treatment that's not working, and what do we need to tweak or change or look at. And so here, in administrative discharge, we are often misjudging the meaning and consequence of administrative discharge. So even in the case where a negative consequence may spark motivation, rather than increasing despair, shame, isolation, all those things that kind of drive substance use. Those negative consequences, the ones that actually do tend to drive motivation, are the ones that are naturally occurring and are primary for basic needs. So things that fall into this category, for example, are losing a job after not showing up to work because of a hangover. What doesn't fall into this category is a punishment, like someone just saying, because you use drugs, now you can't be part of our treatment program. That's not a natural consequence. That's an artificial consequence. And so really here, keeping in mind that the hallmark feature of a substance use disorder is continued use despite consequences. And so something that I really like to kind of tell my staff and treatment programs and talk with folks about is, if punishment was going to work, it would have worked by now, right? It would have worked when they were an adolescent. It would have, and they got grounded or they got suspended from school, right? It would have worked when they got that first DUI. It would have worked when they were, in drug court. It would have worked when they lost that first relationship because of substance use. But there's been, by the time that people reach treatment, many times there's been so many negative consequences that if me punishing them was going to work, then I probably wouldn't be meeting them. It would have worked by now. And we wouldn't really be dealing with a substance use disorder. What we would be dealing with is someone made a mistake and then made a different choice. But a substance use disorder is characterized by compulsion to use despite negative consequences. And so here, really taking a step back and reflecting on, who are we to levy a punishment on those who we seek to help? And how can our punishment even compare to everything that people have already endured because of their substance use disorder? And so I know that some folks are thinking, and I've been there too, but we all know someone who said a kick in the pants was what they needed at the time, right? That negative consequence was what set them on the right course or helped them kind of turn that corner. And so here, really considering that for the person who is going to make a big change in their behavior as a result of administrative discharge, they're probably also going to make changes in their behavior from much less severe strategies that don't end up interrupting their care. So if something like administrative discharge is going to actually help someone, then there's probably a whole lot of other things that we can do that will be just as helpful and won't interrupt somebody's care. So I asked you that initial question, what do you think happens after administrative discharge? So we don't have enough data to truly show us a picture of what happens to most people after administrative discharge. But what we do know is that medication-assisted treatment saves lives, reduces disease, helps people return to work, and reduces rates of incarceration. So especially for people who are living with an opioid use disorder, involuntary termination from medication-assisted treatment increases their risk for very serious negative outcomes. So to cut people with an opioid use disorder off from medication-assisted treatment, for many people, it feels like they have no choice but to go back to using. And so while we don't have enough data, here is one research study that showed us a picture. This is a snapshot of what happened to these 35 people. So this research study followed 35 people for 90 days, and these were all people with an opioid use disorder who involuntarily discharged from outpatient-based medication-assisted treatment. So the vast majority had a lot of difficulty with tapering off medication and the resulting withdrawal. Many became homeless, particularly when housing required participation in treatment. They all saw increases in problems related to physical and mental health. The vast majority returned to use, or if they were already using, their use increased. And 13 out of the 35 reported engaging in criminal activity in order to finance their use, and 4 returned to transactional sex work. So we see that out of these 35 people, there really wasn't a single one who had an aha moment because of their administrative discharge. Instead, all of the things, all of the recovery capital that aids in our path to recovery was severely restricted and decreased for these people. So another clinical dilemma, an ethical dilemma that gets brought up by administrative discharge. So many of the reasons given for administrative discharge are often behaviors that have little to do with recovery and a whole lot more to do with power struggles, which raises the question of whether people are receiving administrative discharge because of true safety issues or because of a power dynamic that gets played out where we as treatment providers are trying to kind of exert control or power over the people that we're serving, or just our escalating negative countertransference. So some of the reasons that are given for administrative discharge are, for example, oversleeping or not going to bed on time, which we know that, especially in early recovery, our sleep is very impacted. Having food or candy or soda in our room, which we all like to have control and power over what we eat, and especially in our recovery, having access to more of those sugary foods, many times there's a craving for it. That's really natural part of recovery. Making phone calls when we're not supposed to. And we also know that a lot of substance use is driven by loneliness, by isolation, and that connecting with people is really helpful. It's really, many people would say, essential to recovery. And so, if I'm breaking rules in order to make a phone call, that tells me that I have a need and a drive for connection. And how can we facilitate that as a program? How can we take that strength and facilitate it rather than, discharge someone from treatment because they broke a rule? And so administrative discharge, in these cases, we see a real adversarial process where we've built up negative experiences and expectations of the person in treatment. We've kind of gotten stuck in our perspective of person and aren't able to see them as the whole, holistic, mind, body, spirit person that they are, and that the ultimate exertion of power by staff is to discharge someone against their will. And so here we see a countertransference getting really played out, and we'll talk more about solutions of what to do with that. And so I have an example I want to share. I was providing consultation for a program, and it was a residential program, and I was asking them about, what are their processes if somebody experiences a return to use. And the response was that it really depends on the situation, that if they would create a sobriety plan and offer support to the person who had had a lapse, if that person expressed, if that person expressed being really sorry about having used, and if they were otherwise easygoing and easy to have in residence. But that if the person was deemed to be a, quote, troublemaker and caused conflict in residence, that then they would be discharged against their will. And so what became very clear as I asked that question was that it was more that what happened to someone if they used while in treatment was more about how the staff felt about the client from the actual behavior of using substances. And so here especially we see what we can call a reverse creaming. So creaming is when we only take clients into our treatment programs who have the best chance at recovery, who have the best prognosis for recovery. Reverse creaming is when the least liked, least engaging, and those who are deemed to be, quote, the most troublesome or most exasperating clients are skimmed off the caseload through administrative discharge. And I want to make it very clear that I don't want to communicate judgment about this. I want to talk about this in a very matter-of-fact manner. These are things that happen in our treatment programs because of context, because of different things deriving these phenomenons, not because anyone is a bad person or wants to hurt people or wants to judge people. We're all in this profession because we're called to help others. And so it's really the context and that derives some of this exasperation, and which ends up resulting in administrative discharge that can come at a really high cost to people's lives even. So we'll get into the solutions of how to address some of those contextual issues so that we don't feel like we have no other option but to kind of discharge someone because of escalating negative countertransference. And so another piece around countertransference is that it's often informed by our past and current sense of safety and vulnerability, as well as our personal defenses. And so this is where it becomes really important to have a self-awareness, and that to have an awareness of, if I'm not feeling safe in my work environment, what needs to happen on the system level in order to increase a sense of safety for everyone, a sense of support for everyone. We also know that countertransference is very much informed by societal stigma of substance use and addiction. And so something that we can consider is, how is this stigma of substance use showing up in our treatment centers? And then this countertransference is a potential vehicle for bias within our institutions. And from some evidence collected here in Illinois, where I'm based, we see that the people who are being administratively discharged disproportionately are people of color. And so this calls into question, how does bias get played out in decisions of administrative discharge without us ever knowing it? So it's not that, we are seeking out or targeting people based on their social identity or their racial ethnic makeup. This is all happening kind of subconsciously, and implicit bias getting played out in this way. But things to reflect on. And so coming back to that ethical duty to address a lack of progress. So here, we absolutely do have an ethical duty to address a lack of progress in treatment. The first question is, how are we measuring progress? Are we using standardized scales to measure progress? Are we just kind of deciding amongst ourselves, and how much is our subjective decision making based on things like countertransference and bias, and maybe people who are able to maybe hide some of their struggles a little more so, and we're kind of bought into it, and so how much of our assessment of people's progress is actually multifaceted and evidence-based, right? It's not just based on a drug test, for example. And when we do detect that someone is not responding to treatment in the way that they would hope and in the way that we would hope, it's important for us to take some responsibility in selecting and applying treatment services that are responsive to the person's need. And so the ethical dilemma that gets played out here is that we, in administrative discharge, we're laying the blame on the person for not working hard enough. And we need to ask ourselves, are we putting people through the same treatment protocols again and again? Are we taking kind of a cookie cutter approach? And how might our system be setting people up for failure when we need to be individualizing treatment and being really responsive to the person showing us that our treatment isn't working in the way that we had hoped, and helping to really craft some solutions. And so in this way, we don't see that the person isn't working in treatment. We ask, what about the treatment isn't working? And there are absolutely times that someone will need a level of care that is not provided within our programs. And so if someone needs a level of care that we aren't able to provide, this is where it's important. We have an ethical duty to ask ourselves, what are we doing to prepare them for engaging in that level of care? How are we assessing the barriers for them to that level of care, both internal and external barriers? How are we applying things like motivational interviewing to help them prepare for that next level of care? What other recovery support services are available? What are we doing to successfully link them? What MOUs and linkage agreements do we have in place? And recognizing that someone may need a service that we cannot provide, but that is not grounds for discharge, right? It doesn't mean that we do nothing, but it's not grounds for discharge. And then coming back to financial concerns. And this one, I just want to say a shout out to all the administrators on the webinar this morning. I get it. You know, when it comes down to keeping the doors open, that is very real, and we do have a responsibility to our staff and to the people we serve and to the community to keep our doors open. And so what do we do instead? So the ethics regarding financial concerns, we need to have transparency surrounding costs, including the estimated out-of-pocket costs. We need to have realistic assessments of a person's ability to pay. And then flexibility with offering payment plans and alternative means of funding when individuals are unable to meet their out-of-pocket costs. We know that an important part of recovery capital is insurance resources, financial resources, access to treatment. And so part of our role is doing everything possible to help that person access treatment even when their financial resources are low. And within our publicly funded programs, administrative discharge due to inability to pay really has no place in publicly funded programs. This is why there are federal block grants available. This is why there are a lot of different funding made available for individuals who have an inability to pay. And so in this case, it truly does raise the ethical issue of clinical abandonment, and that in many places it will not be allowed by legal and regulatory standards. So what now? That's the end of my deficit-focused part. Thank you for bearing with me. We've covered many of the concerns that lead to administrative discharge, as well as the clinical and ethical problems it poses. So now we're going to move into what can we do? So before we do that, we're going to take a short break. So if we can come back in 5 minutes, I have 10:02 on my time. If we can come back at, well, you know what, actually? No, you know what? We'll go ahead and save questions for the end. So if we can come back in 5 minutes, that'll be great. So if we can come back at just shortly before 10:10, like 10:08, 10:09. Thanks so much, everyone. I'm so sorry. I just realized I gave you Central Time for time to come back. So if you can come back at like shortly after 11:10, so like, 11:08, 11:09. Thanks so much, everyone. All right, welcome back, everyone. And now, moving into solutions, promising policies and practices for decreasing administrative discharge. And so all the things that drive administrative discharge are very real. They're not, they're not imagined concerns, they're not imagined problems. They're all very real. And so here, looking at some concrete strategies that can help us reduce administrative discharge. So starting with pre-treatment engagement and orientation. And so really looking at to maximize the beginnings. The beginnings of treatment episodes are crucial for setting the tone for the treatment experience and those beginnings naturally bring up anxiety and confusion for the person entering treatment. I remember a person after they'd been in our treatment program for a while, they said, I feel like I had to learn a whole new language when I came to this program. And as much as I wish that wasn't the case, it very much was the reality for her. That was her experience. And so looking at even before someone enters our treatment, what are we doing to help orient them to our services and to engage them? And so the unfortunate reality is that most of our treatment services don't have same-day access to treatment. That really, when it comes to wrapping our heads and our arms around this epidemic and helping people stay alive, the best thing we could do is have treatment on demand, same-day access, but that's just not the reality. Our systems have not been set up that way at this point. Hopefully we're moving towards that, but at this point it's still not that way. And so creating pre-treatment programming helps prepare individuals for beginning treatment, helps address any barriers they may be experiencing, as well as help support their engagement and really building up their recovery supports so that they can have the best treatment experience possible. So some things to consider in the pre-treatment engagement and orientation. How is our orientation culturally responsive? When I'm experiencing orientation, is there different ways of understanding information so that, if I'm a visual learner, if I'm more of someone who needs to walk through the space in order to feel safe and welcome there? Do I see people who look like me in staff roles? Is it, is the environment responsive to what, my cultural background is? And then how do we demonstrate transparency and trustworthiness? I was consulting for an organization once that their women's residential unit got less smoke breaks than their men's residential unit. And the women weren't told this as they were going through intake, and then once they get up on the unit, they would get their handbook and they would receive this information, and they would be really, really upset. And when the question was posed to the intake department, okay, well, how come the handbook can't be made available at intake, and how come this isn't something that's being discussed with the women as they enter treatment? The response was, well, if we told them that, no one would come into treatment. So that, from the very get-go, is a lack of transparency, which then translates to a lack of trustworthiness. And so a question that was it's a hard question to ask ourselves, but it's an important question to ask ourselves is, what part of our program do we feel like we have to hide or we can't really be upfront about at intake? What's our program manual look like, and what are the things that we kind of gloss over until someone's in treatment, and why? Because if we have to hide it, there's probably something that needs to be changed about it. How do we engage natural recovery supports so that we're helping someone to engage in a community of recovery? How do we involve peers in the orientation process? I remember we were doing an intake with a young lady, and she was mandated through Child Protective Services, and she was not thrilled about being there with us, right? This was not in her plan, and she felt that this was, rightfully so, she felt that this was another barrier to her ultimate goal of family reunification, and she really didn't come in seeing us as an ally in that process. And I remember we were talking with her and explaining to her some of the different program services we offered, and she just, completely turned down groups. She was like, no, I don't want to hear, anyone else's story. I don't want to tell anyone else about myself. I shouldn't even be here. There's no way I'm doing groups. And we're able to be really flexible and just say, that's fine. We're not here to force you to do anything that you're not willing to do. If you don't feel that that's helpful to you, then we're not here to force that. And if that changes or you want to just try it out, know that you're not forced to say anything in group. You're welcome to just listen. You're welcome to try one out and never go back, really trying to offer her the options. And then we had her on her way out, just introduced her to the group was actually getting out at that point. We just introduced her to some of the different group members as she was ending her intake and leaving. This was in an outpatient setting. And just, introduced her to some of the more senior members of our treatment group, some of the folks that were a little bit farther along in their recovery process. And she had such a grounding experience talking to some of the people who have been in our treatment a little bit longer and had some of those recovery gains that completely unprompted, she just said, yeah, I'll see you tomorrow at group. I'm definitely going to be there. And, that wasn't an experience that we were the right people to kind of communicate to her, but hearing it from someone that was actually in the treatment program, hearing it from someone who was her peer was what made the difference for her. And so looking at how do we involve peers in the orientation process, people with lived experience who have been through our treatment or are part of our treatment, as well as people who are employees and staff in our program who are people with lived experience of recovery. And then looking at how do we inspire hope and connect with people's core values. So I remember doing an intake, and someone said to me when I asked them, what do you do in the services and how can we be most helpful to you? And they said, well, I want to get sober. I want to stop using drugs. And I said, okay, and what else? And they kind of gave me this puzzled look like, well, what do you mean? You're a treatment provider. Why else would I be here, right? And I was able to say to them, I want to hear about all the things that not doing drugs would help you to do in your life. Because my guess is that if you could do all the things in your life and continue using drugs, that I wouldn't have the chance to meet you today. So what are the things that recovery is going to make possible in your life? And then we can have a real conversation about how I want to be there for my kids, how I want to, go back to working, how I want to live independently, right? All the reasons that recovery is worth it. Because at the end of the day, as one client said to me once, if recovery was just about giving up drugs, I'd have no reason to do it. And so how, throughout that pre-treatment engagement and as well as treatment orientation process, how do we inspire hope? How do we connect with what's most important to them? And along with that, recognizing the power of relationship. That when we create a relationally oriented healing environment, that then we have much more of that kind of social capital to fall back on. That then we can have a better understanding of people when they are showing us with their behavior things that they're not able to tell us yet. But then we can have a much deeper understanding and recognition of people as people. And so there are some pieces that go into the relationally oriented healing environment. One is having a primary staff member assigned and having that one-on-one attention and support, and having typically even more of that at the beginning of treatment to really maximize that beginning. And because starting anything, even if we've been there before, even if we know exactly what to expect, it's still change, and change is still hard. And that there's that ongoing engagement, the processing of their negative emotions, affirming of any positive change, a lot of times people come to me and they say, well, like I've been coming here for a month and I don't see anything different. And it's my job to find those sparks, all of those mini wins that they've had, that they kind of just look right over, and to really affirm the gains that they are making and really root those in qualities that they have, that they are making this happen, as well as that early identification and resolution of problems that are coming up, right? Even good change is hard. And so what are some of those problems that are coming up, some of that loneliness, some of that trouble sleeping, right? Some of those things that we can help suss out and support someone with before it becomes a big thing. And in this way, the importance of multidisciplinary staff, including peer recovery specialists, people with their own lived experience of recovery. Because at the end of the day, we know that relationship is one of the most evidence-based interventions, right? We don't have a client until we have a relationship. What we can't predict is who someone might form a relationship with. There are some basic things we know that are important, like compassion, empathy. But, we can't always predict that if I have compassion and empathy, my coworker has compassion and empathy, who it is that person, that client, is going to really connect with. And so that's where the multidisciplinary and diverse staff becomes really important. I remember there are a whole lot of people who really were so sick of talking to a counselor, just like so sick of it. And I feel them. I get it, right? And then the moment that we hired a peer recovery specialist, it was like people were lining up out the door wanting to talk to the person who they felt like they could be best understood by, and how important that is. And then the continuity of that relational support. So it's not, every time I get comfortable, there's someone else I have to learn. So being able to assign a staff member who provides that continuous support throughout every phase of care, from the pre-treatment to the aftercare, and how that helps increase a person's sense of safety. So it adds to a sense of stability throughout the various transitions in treatment, especially if we have multiple levels of care and staff are assigned to a discrete level of care, being able to have that one person who's your touchstone throughout, from your very first contact throughout your aftercare. And this, those transitions, right, change is hard. Even good change is hard. And so those transitions can certainly have some reactivity. There can be some increased vulnerability during those transitions. And so having one assigned person to walk alongside that person through their treatment trajectory can really decrease the reactivity to some of those changes. And a recovery coach, a person with lived experience of recovery, is in a really good position to provide this kind of continuous engagement and support. Minimizing rules and maximizing engagement. Now, this is one where sometimes I hear the cries of anguish, right? Well, what do you mean minimize rules? What happens when we minimize rules, right? There's a lot of fear around it. And so one of the cornerstones of preventing crisis is choosing limits wisely. So it doesn't mean anything goes. It doesn't mean that there are no rules. But when we have a whole lot of rules, typically what ends up happening is that we end up as an enforcer rather than a counselor. Rather than someone who's aligned with, we end up someone who is kind of policing. And the most important rules kind of get lost in the mix because there's so many different rules to try to remember and follow. And especially in early recovery, when we're just trying to make it day to day, trying to remember a whole bunch of different rules isn't exactly helpful. Structure is helpful, but not a whole bunch of rules that can seem somewhat random to us. So minimizing rules, choosing our limits wisely, and too many rules can really damage the relational environment, and it becomes just an environment of control. functional behavior analysis. So considering behavior as just as an important source of data on how the person is currently doing and their ongoing needs. So rather than, oh, you use substances and now we're here to punish you, right? But actually looking at what is the purpose? What was the purpose of that substance use? What need was the person trying to meet? Understanding that substance use is an attempt at a solution, which most often has become a problem. So what need was that person trying to meet? And then from there, what changes are needed in the service plan to better meet their needs? What can we learn from the situation to better support the person? And what can we learn and what can we help the person learn through eliciting their insight and their motivation? So not an authoritarian top-down, you're in trouble, I'm going to lecture you now, right? Like we have all been on the receiving end of that and I think many of us have felt more shut down than anything else, right? And our defenses get raised. Instead, being able to really minimize shame and have an open, collaborative conversation. And so the person can actually feel open and vulnerable and learn, seeing that vulnerability as strength and that we're not here to punish them when they open themselves up. But really seeking to understand behavior as something that someone is maybe unable to verbalize yet and helping them to verbalize it as opposed to labeling their behavior. Another critical aspect is ensuring the therapeutic dose of medication. So especially where there is opioid use disorder, or we know that naltrexone has also shown evidence in supporting people in recovery from alcohol use disorder. We know that other medications are in the research phase. But what we've seen time and time again is that when people don't have enough of their medication, it contributes to behaviors that often lead to administrative discharge. And so if somebody is continuing to test positive for opioids when they're on medication-assisted treatment for opioids, that doesn't mean that they need to be cut off from medication-assisted treatment. That typically means that they need more medication-assisted treatment, and it may mean that some other interventions are needed. And really looking at, if somebody comes in, somebody was prescribed a pill for high cholesterol and then came in and their cholesterol was still high, right? We wouldn't take them off their cholesterol medication. We might say, oh, okay, maybe more is needed, maybe different kinds of medication is needed, maybe there's some additional support you need, right? So really using that as information to make sure that the therapeutic dose of medication is being provided. And then if we see somebody testing positive for other substances when they're on medication-assisted treatment for opioids, not being shocked by that medication-assisted treatment for opioids has only been shown effective for treating opioid use disorders. So it really, if somebody tests positive for marijuana or cocaine or methamphetamine, that has nothing to do with the fact that they're on methadone or buprenorphine or Vivitrol, and it has everything to do with, okay, what might be some other treatment needs? MAT is only one treatment tool. There are many other tools that we need in our pathway of recovery. Clinical supervision. So I mentioned caffeine earlier, and here I have my coffee cups. I am a lover of the coffee or tea, but really taking that time to connect with staff. So high-quality clinical supervision is the cornerstone of clinical infrastructure. It's required for quality assurance and improvement within our treatment settings. Supervision is truly essential in order to recognize and dismantle negative countertransference, in order to support our staff growth and in their competencies, as well as develop responsive care plans for persons served. And so, while I know in a lot of our settings, it feels like we're just running from one thing to the other, just next. And it can feel really hard to carve out that time. It is essential to carve out that time. In the military, we talk about having a force multiplier, right? That a force multiplier is something that has an exponential effect. So it's not 1 + 1 is 2, it's 1 + 1 is 20, right? And so with clinical supervision, this is one of our force multipliers. That through clinical supervision, it's how we enhance our programming, support our staff so they can be in the best possible place to support the people we serve. And that really, this is the crux of good practice. And then, excuse me, let me add, there's a lot of ways to provide clinical supervision. It can be one-on-one. There can be group supervision. There can also be peer supervision and support, where staff are meeting with one another and debriefing. So we can be really creative in how clinical support and supervision is provided. And it's many times better to have a mix of all those different kinds. Another solution strategy is having a protocol in place for reviewing discharges. So rather than someone in isolation or maybe just a couple people deciding, okay, we need to administratively discharge this person, there we go, paperwork's done, person's discharged. Instead of that, having a process in place where anyone who seems to be headed for administrative discharge is reviewed. And during that review, we can identify alternative strategies. We can help identify whether there are some countertransference issues at play. And we can help prepare and make some plans for that person's continuity of care. Doesn't mean that there's never going to be a time where administrative discharge needs to be used. I don't work in your setting. I can't be the one to say that. But this is a strategy to help prevent it being misapplied and overused. And, right, prevention, helping to catch this well before we're kind of at that point we feel like that's the only option. Protocols around effective transfer to support continuity of care. So transfer is always preferable to administrative discharge. So effective transfers to different levels of care, different service environments, different treatment modalities requires us to be flexible to use our linkages and follow-up to ensure that continuity of care. So this is where it's important to have an awareness of other providers in our community, what some of their eligibility requirements are, to have some relationships in place. And absolutely, there were times that, when I was overseeing intensive outpatient, that someone really did need a residential stay. And so, working with that person in my treatment center to help develop some of that insight and address the barriers to them going into a residential treatment stay, while also making sure that I had relationships and knowledge of programs that would be best suited to meet that person's needs so that I could do that warm handoff and that linkage. And then having releases of information in place so that we could stay in contact. And then when that person was ready to step back down to intensive outpatient, that was done in a way that was planned, that supported the person's care, and that wasn't just them showing up at my door saying, oh, yeah, I finished a month ago, right? And it's like, what happened? How did we not know, right? But that's done in a way that's really thoughtful and deliberate and focused on what the person needs in their recovery. And I've seen, especially as an intensive outpatient provider, and we saw that the highest number of administrative discharges tends to be from outpatient and an intensive outpatient, that was a really, really important recipe for a lot of people's path forward. And I saw that even just having that 1 or 2 week residential stay really made a difference when they came back and stepped back down. But always done with the person, with the person's desire and willingness, but also knowing that willingness and readiness is something that as providers, we can have an impact on when we're using things like motivational interviewing. And then the practice of recovery checkups. So recovery checkups are this really fabulous process that helps us really appreciate that substance use disorder is not something that is just, you go to treatment, you check it off a list, and now it's done, right? But it's something that we build a life of recovery, and that it's something that is of long-term duration. And so there's no other chronic condition that we would just say, oh, treatment's done, never talk to you again, right? Every other chronic condition, we have checkups. We check in with people and see how they're doing. So this recovery checkups is something that we can especially use if there's an administrative discharge, but best practice is to use it for everyone who completes our treatment, everyone who we can get a hold of, everyone that we have contact information for post-treatment to really provide these recovery checkups. And so we can check in with people, shortly after treatment exit, 3 months after, 6 months after, even, up to, some people do it up to 18 months after. And they help us to check in with the person, see how they're doing, see whether they need help accessing any kind of recovery or treatment resource, see whether, and it helps us to re-engage people if they are experiencing some substance use concerns again. In the context of administrative discharge, here are some things we want to pay some special attention to. We want to define conditions for readmission and resources to support the person in meeting those. So what would be needed for this person to be able to access our treatment program again? And what are some supports, potential supports for that person to be able to meet those conditions? We want to provide some linkage to community-based recovery support. And at the end of the day, it's essential for us to keep the relationship as healthy as possible. I have seen time and time again throughout my career that if we can keep a person alive or help keep a person alive, obviously it's not our response, it's not within our control to keep someone alive, but if we can help keep someone alive and keep a healthy relationship where they feel like they're always welcome to walk in through our doors. I've seen recovery happen in such amazing ways. I mean, people whose situations just seemed like they had so many barriers. See them build a life of recovery and really having that long-term perspective of recovery is always possible. And so keeping the relationship as healthy as possible so people feel like they can always reach back out to us. And this takes us valuing and expressing their absolute worth, dignity, and value, no matter their discharge status. And so keeping in mind that administrative discharge can often be a very adversarial process. It often happens when there's been a lot of built-up negative feelings on either end. Just the importance of someone feeling like they're always welcome to reach back out for help. They're always welcome back into our doors, and that recovery is always possible. Creating feedback loops. Now, this is more of a system thing. And on the ground, practitioners can certainly do it very informally, but from a systems level perspective, being able to build in some structures around this practice. So creating a feedback loop between discharge and assessment and admission. So looking at how can we improve assessment and level of care placement in order to increase the effective treatment planning and increase the likelihood of treatment completion? As well as looking at what needs were not adequately addressed at intake that later led to interruptions in care. So one prime example is assessing for caretaking needs. And so not only is childcare a very, very scarce resource, especially for people who may have reduced financial resources or social supports, but really any caretaking need that many of the people I served throughout my career not only had children in their care, they also have had other family members in their care, partners who had a disabling condition who relied on them for care, aging parents who relied on them for care. So really assessing for those caretaking and caregiving needs from the very beginning. As an example, assessing for transportation needs at the very first contact. There was some really interesting pilot level data available through NIATEX that looked at the simple question of asking people when they were scheduled their intake appointment, how do you plan to get here? That it really helped identify if folks had any kind of transportation barriers and helped engage them in some problem solving and brainstorming around how they could get to their appointment. But that even for those people who didn't need a referral or a resource in order to overcome any kind, didn't really have that concrete transportation barrier, but it just helped them kind of in their planning and thinking like, oh, I need to ask this person for a ride, or, oh, I need to make sure that I have access to the car that day, or, just helped kind of kick off that planning process, and that missed intake appointments were greatly reduced by just adding that one question to the appointment scheduling. And now focusing on how we can support our frontline clinicians. Really the heart and soul of our services. So for the frontline clinician, first and foremost, strive to connect with each person as a human being. And so this really calls to the heart of why we're in this work. At the same time, there's so much paperwork and there's so many procedures to kind of get through, right? So this calls upon us to find ways to rise above the paperwork and really personalize our services for our clients. So spending time with our clients with no paper or treatment task agendas, just spending some time with them to get to know them, each as individuals, finding ways to increase some of that one-on-one time with our clients. The quality and the frequency of positive contact is often more important than the time involved in any single contact. So really looking for that like quality over quantity time, and that kindness, respect, and unconditional positive regard go a long way in addressing some of the apprehension that people have when they enter into a helping relationship with us. Noticing interpersonal styles and ways that people make as well as avoid connection. And so noticing that we all connect in different ways, we all communicate in different ways, and really not taking it personally when different situations may come up, but taking it more as information. And so this is, if we find that someone is maybe hesitant to talk to us, there's maybe even saying things that are meant to push us away, being aware and noticing that connection may feel really risky for that person at that time. And noticing that maybe for that person, a different approach is needed as we help demonstrate our trustworthiness. And trauma-informed care, plays a big role here. So here, really separating the condition from the person, understanding that that many times when we might feel very natural feelings, because we're human too, of anger, frustration, disappointment towards a particular person in our care, separating that person from the disorder, and that disorder has been a means of coping for that person, but that is not their true essence, that is not their true self, and that so much of that healing process is us being able to see that person's core qualities and core values underneath all of the life stuff that's happened, and being able to really reflect that to them. Being able to, through our relationship, that person be able to see their true essence as we reflect it to them. And so getting past that kind of crust of the disorder to the person who's truly underneath that disorder is the very essence of our counseling. Using peer and clinical supervision. So I remember it was such a turning point for myself when I was a young clinician, that every time I felt like I was out of options, or I felt like I just didn't want to call that one client back, or I just hoped that client would miss their appointment, right? Like all those things that so naturally come up for us, that when I realized, oh, that means I need to consult about this person. That means I need some support around this situation. When I was able to kind of put those two pieces together for myself, my burnout decreased, my ability to feel for hopefulness, to feel like I could make a difference increased. And so being able to see that that when we feel like, gosh, nothing I'm doing is working, and I'm all out of options with this person, or I feel that frustration, or I feel that avoidance, that oh, okay, let me seek out that support, let me seek out that supervision. And so seeking support is not a sign of incompetence or a lack of kind of emotional resources, but it's actually the very epitome of professionalism, and it's the best way for us to really counteract that compassion fatigue and that burnout. And that, this is why they say two heads are better than one, right? I remember being in a clinical staffing, and the director, I was frontline staff, and then had my manager, and the director was in the meeting, and the director was expressing some concern about the lack of progress for the client that we were discussing. And I remember just being able to say, it's a process. And the director stopping in that moment and saying, thank you for that reminder, Gabriela. It is a process. And we were just getting ahead of the client, and we need to slow down and really meet the client where they are. And so, no one of us is the perfect clinician. No one of us knows what to do at every moment. If anything, more experience means we're more comfortable with not really knowing what to do at any given moment. And that's where really having that peer support and that clinical support is so important. And then going the extra mile to engage and support those who have had multiple treatment episodes. I was giving a training in Kansas last week, and someone there said, something that's really helped us is that we embraced the revolving door. And I thought that was a really interesting way of putting it, that so many times when we see someone return for multiple treatment episodes, sometimes we can feel like, wow, what we're doing isn't working, or this, here we are again, here we go again, right? It can be a source of frustration or other negative emotions. And that really reframing that to be able to say, wow, this person, after so many times, after so much trying, still has hope, right? They still have hope that something can be different, and they still trust and believe that we can be a part of that process, that there's something that we can do to help them. And so rather than feeling like avoidance or frustration for people who have come through our doors multiple times or feeling like their prognosis is not as positive, really going the extra mile to engage and support them and figure out what's helped in the past, what hasn't been so helpful in the past, and what do they see as being helpful this time. And so we know that most people will need multiple treatment episodes before they are on that path of long-term recovery. And so this is part of the many pathways of recovery. And so there are different windows of opportunity that open in all of our lives. And sometimes it can be something as simple as just there was that one person that one time who just understood me, who just saw me for my true self, who just really got me, who believed in me when no one else did, right? And so we can be that person. We can be that one person. And then I mentioned this briefly, but really embracing and rejoicing in the multiple pathways of recovery. That there is no one-size-fits-all. There is no cookie-cutter approach. Just as we all have different fingerprints from the time that we are fetuses in the womb, each of our recovery journeys is absolutely unique, and that most often people use many different kinds of supports and pathways of recovery on their overall journey of recovery. And so the good news is that there's so many different ways of recovery and the styles of recovery initiation. And so our job isn't to try to determine for someone what their pathway may be, but to help each person use the building blocks of their own individual experience and those who have recovered before them to really build their approach of what's going to work personally and what's going to be culturally responsive for that person. And so one thing for us is recognizing how our own vision of recovery may influence how we deem whether or not someone is making progress and how we deem whether or not treatment is going to work for this person, and being able to take a step back and really widen our perspective and embrace all the different beautiful ways that recovery happens. So we've now arrived at question answer. We have about 8 minutes together before the evaluation portion. So I'd love to take any questions people have. Oh, this is a great question. So is there a tool that I could use to complete an internal review of discharges? That's a great question. You know, I'm not aware of any standardized tool that's available. I imagine that what I would suggest, and something that I did in my own programs, was that I collected data on discharge reason, length of stay, you know, some of those other indicators like whether they were working, what their housing status was, you know, income status, things like that, as well as some demographic categories, gender, race, ethnicity, things like that, age, of course, and then looking at together who tends to have positive outcomes in our program and who is our program not working for. So that then we can start looking at even like population health, right? If our program isn't really working for young folks, right? If we're seeing that people who are 25 and under either don't really come to our program, or they come and they're there for a session and they don't come back, or they don't complete our program, what do we need to add in order to be more responsive to the needs of young people? If we see that, using that same example, that young people are being more administratively discharged, then what do we need to be more responsive to their needs and to understand some of the core developmental features of that life stage, right? Pushback and independence is absolutely normal it's absolutely normal for everyone, let me just say, as a very independent free thinker that I like to consider myself. But it's especially normative during our later adolescence. And it's a really good sign when people are trying to think independently. And so how can we embrace that rather than try to, exert power over it? Nakisha, who asked this question, if you end up coming up with a tool for your program, feel free to shoot it over to me. I would love to see it. Thanks for that question. Do you have any resources that could be provided to our superiors that would support the need to have supervision in various formats? I think that it really depends on, so everyone has different styles of how they like to receive information. A lot of times people who are in administration like to see hard numbers, but there are some people that are more responsive to kind of the people stories, the stories of what made a difference. And so in that, I believe that there are some supervisory toolkits that not only spell out some of the different ways that supervision can occur and some of the different kind of core processes of supervision, but also some of the positive outcomes that come out of supervision. So if you want to email me, my email is going to be on that last slide. I can make sure to send you some links and citations for some of those supervisory toolkits. Let's see. Yes, thank you for your question, Monique. So earlier I mentioned that some of the data here in Illinois, and we still don't have great data nationwide, we need to have better data, but that at least here in Illinois, some of the data we have points to that it's disproportionately people of color who experience administrative discharge, and what's being done to correct that issue and keep people in treatment. And so I think that absolutely the majority of providers have a dedication to culturally responsive services, which is a very, very important piece of that foundation. Now, I would add that it's only one piece. So we need to have services that are culturally, and there's a lot of ways to say this, right? Culturally sensitive, culturally competent, culturally responsive, culturally humble. There's a lot of ways that we talk about cultural responsiveness and a lot of different ways to think about it. What I would add is that we can't stop there. That's one piece of the puzzle, and another exceptionally important piece is anti-oppressive practice. That implicit bias is something that we all have on some level, whether or not we realize it, and that when we're not aware of it, that then our institutions, that implicit bias gets built into our institutions. And so we need to have anti-oppressive practices and protocols that uncover those implicit biases and correct them. And that's probably a much larger discussion than I could say in the next couple minutes. But thank you, Monique. One question, should treatment centers and facilities uphold some rules and not minimize all rules? Absolutely. There needs to be some rules, right? We can't do an anything goes kind of thing because we know that structure is an important part of recovery. There needs to be some rules, and those rules, the number of them need to be minimized, so it's just the most important rules. And we need to have transparency around those rules, and we need to have opportunities for people to be reminded of those rules and have open, person-centered conversations, do that functional behavior analysis, and then collaborate in that solution making so that people are part of the solution and that it's seen as part of their treatment need rather than something that we are here to uncover and punish. And that's going to be different for each center, how those rules get made and translated, and that's a really important process for each center to determine for themselves. Well, thank you so much, everyone. I know we only have 1 minute left, and I want to make sure that I share my contact information. Here is my email. Here's my LinkedIn. My website is not up yet, so don't go to my website. There's nothing there yet. One day I'll figure out how to build it, and then there'll be a website. But otherwise, feel free to connect with me on LinkedIn and Gmail. I see there's still a whole lot of questions left. I'm really sorry that we didn't have time to get to all of them. Feel free to reach out to me, and feel free to indicate if you feel that this is a topic that we need to have further discussion and learning about. Thanks so much, everyone, for joining us today. And I'll turn it over to Diane.
Thank you so much, Gabriela. This was a great webinar, and just thank you for your time and your knowledge. So as we conclude today's webinar, your browser will take you to an evaluation on FADA's new website. If you want to receive CE credits or a statement of credit for this event, please complete the evaluation. You must complete the evaluation in order to receive a statement of credit. And if you have challenges, please contact our office. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. For CEs to be reported to CE broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number the first time you register. After you register or sign in, you will be directed onward to the evaluation. You may consider using the same email address when you register for webinars through our WebEx link and when you set up your profile on FADA's system. This helps connect your attendance and your profile. So we use your email that you registered with and your FADA visitor or member email to compare to reconcile the event. So if those two are not the same, then you will want to call us. You will get a second opportunity to complete the evaluation through a follow-up email. The sender will be Messenger at WebEx. Evaluation will close at midnight on Thursday, May 16th. It will, if the evaluation is not completed by Friday morning, the evaluation will close. So we need the evaluation and your attendance in order for us to give you a statement of credit. We do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile. I will send an email when this has been completed to the email provided on your attendance on the WebEx registration. Thank you for participating in today's webinar. We'd also like to recognize and thank especially the Florida Department of Children and Families Office of Substance Abuse and Mental Health for funding today's education. Have a great rest of your day, and please hold for the evaluation.